Thank you so much. I'm really thrilled to be here. Just to say, I think my talk's going to be on a little bit of a different kind of note than the others, in the sense that I'm really going to sort of dive into some of the issues of ethics and governance. Some of the things I'll talk about will definitely overlap, especially with things that were said before on the regulatory side, but also stuff that Patricia was saying in terms of really thinking about the relationship of trust and providing the kind of support and proper information to clinicians and those who are going to be actually using the AI and digital pathology. So let me start out by basically introducing a kind of vertical use case that can give us a bit of ingress, I would say, into how we might think of responsible data innovation ecosystems in digital pathology, and that's the use case of COVID-19. We all know that COVID-19 accelerated many things in terms of technology, and in the sort of field of biomedicine and the field of data science as a support tool in medical research. This was absolutely the case, and this came with benefits, but also with some sort of frightening warnings. So basically, what I wanted to quickly talk about first is one of the things that happened at the very beginning of the pandemic is some institutions got together to take up a kind of project of UK's Rapid Response Data Science Task Force for COVID-19. It's called Dekovid. And Dekovid basically used detailed and frequently updated health data in a secure database to sort of ask and answer questions, clinical questions that would hopefully support the COVID-19 emergency response. And so I'm going to share with you, my team at the Turing was basically, we were tasked with leading on the ethics on it. And so what I wanted to share with you is some notes from the field. And I really want to ask the question, which is up on the slide: what are the major challenges that we faced in confronting COVID-19 through rapid response data science? And how can learning from working through these challenges inform the creation of an ethics and resource governance framework that ensures sustainable, resilient, and ready data innovation ecosystems for digital pathology? So basically, there were several overlapping challenges that we really need to confront here. First, we found that there were issues related to model reporting, model validation, and clinical uptake. Also issues related to data stewardship and responsible data management. So thinking about data quality gaps, deficient methodological interoperability, data siloing, lack of metadata standardization, issues related to individual and public consent, as well as institutional transparency and social license. Health equity, fairness, and bias mitigation issues arose as we were confronting the use of the data science in COVID-19. Issues related to model interpretability and result opacity. And finally, and probably one of the more important ones, is issues related to the context-aware and interdisciplinary data innovation. So in other words, how do we leverage data linkage with electronic health records and granular patient care data collected in complex environments? And how do we leverage that in complex environments where there are so many confounders that come from the complexity of the use case, the complexity of the clinical practice? So I'm only going to really have time to cover here a few of these that I've highlighted. So I'll talk about a little bit about model reporting, data stewardship, a brief bit about health equity and fairness, model interpretability and result opacity, and then I will finish up by really thinking about some objectives when we think about translating the lessons into the digital pathology environment. So first, issues related to model reporting. This is a study that was now very well known, that was originally published in BMJ by Readiness et al. So they looked at many of the prediction models that had been used for diagnosis and prognosis in COVID-19 infection. All of the 232 prediction models evaluated of these, all but two were high or unclear risk of statistical bias. Wynitz et al. Found that only 5% were externally validated. Quality issues attributed to poor model reporting, poor methodological conduct for participation selection, predictor description, and statistical methods used. And none of the models significantly were recommended for immediate clinical application. In another really important study by Roberts et al., out of 320 papers on machine learning methods to detect COVID in chest radiographs and CAT scans, of those, only 62 passed quality checks with reporting sufficient to warrant inclusion in the review. Evaluation of these remaining 62 studies found that none of the models identified were of potential clinical use due to methodological flaws and on underlying biases. And none of the reviewed literature reached the threshold of robustness and reproducibility, essential to support utilization in clinical practice. Now, these two studies really bring to the fore something that has been well reported in the literature. Anxieties about the lack of process transparency, poor model reporting, and the lack of appropriate validation have already had a direct bearing on the adoption or the lack thereof, application and effectiveness of data-driven decision support in a broad range of clinical environments. Poor methodological conduct and reporting has been shown to exist across many different areas of research and clinical prediction modeling, and that's led to a perceived limitations in the perceived reliability and applicability of such studies in decision support settings. Poor model reporting and unclear methodological conduct function at the end of the day as a stumbling block for the reproducibility of results. And these are often met with justified trepidations by clinicians. Without externally validated research that is corroborated through replicated experimental methods and that supports the generalizability of out-of-sample instances, clinical uptake will be significantly limited. And this applied to COVID-19 and equally applies to studies in the area of digital pathology. So just moving to the issues surrounding data stewardship and responsible data management, this is kind of an ideal schema of the data lifecycle if we follow the FAIR principles. So you can see moving from left to right is the kind of workflow across the data lifecycle. And so just to point out some of the pitfalls we found as we were going through it. First, data quality gaps arise on the side of clinical practice from measurement errors, clinical learning processes, differential resourcing of care environments. If we think of also in the clinical environment, there's deficiencies in methodological interoperability, which lead to uneven data quality across clinical environments, labs, and health systems. Think in the digital pathology context about slide quality and the ways in which annotation practices occur. If we think about broader data resources such as biobanks in genetics, sampling biases lead to imbalanced and incomplete data sets and irresponsible data linkage. This will be just as true if we think of the repositories of pathology slides. Also, if we're thinking about linking data and thinking about the sources that come from sensors and the Internet of Everything, Internet of Things, poor variable sensor quality generates measurement inaccuracies. Now, moving along the life cycle, we found this was an especially big issue in COVID-19. Lack of accreditation and protocols for secure and trusted research environments delayed data sharing and agile collaboration. And this will be also a crucial component when we think about the demands to have a kind of interoperable environment of data sharing when it comes to really capitalizing on what's available in the greater space of sharing pathology slides that are digitized. Moving again now to even further along, one problem that we really confronted between the trusts in the UK was data siloing. Data siloing causes a lack of standardized measurement and recording practices across clinical environments and health systems. This leads to divergent data ontologies and inconsistent metadata categorization and phenotyping, and that can be absolutely devastating when you're linking and trying to combine different data sources, different data sets. So I'm just going to kind of run through this slide. If you're interested in details, you'll see we published this past year in BMJ an article called "Does AI Stand for Augmenting Inequality in the Area of COVID-19 Healthcare?" Basically, this is a warning slide. This is a cautionary slide. And if you move from the top left quadrant across down clockwise, you can really see that, if you start with the real world patterns of health inequality, unequal access and resource allocation, discriminatory healthcare processes, and biased clinical decision making, that finds its way. It has cascading effects as it finds its way into data. And so we have issues of sampling bias and lack of representative data sets. And then we have issues when the actual patterns of bias and discrimination become baked into data distribution. So think here, for instance, to flag up the NLP example, how biased note-taking in a clinical environment can simply become ossified and crystallized in a data set that is just using clinical notes without an awareness of potential biases in clinical practice. Then there's biases, of course, in design practices and deployment practices, power imbalances in agenda setting and problem formulation when the systems are being built, biased and exclusionary design and model building practices. So in a sense, think about how we, how a project team might group or disaggregate variables that have to do with sensitive characteristics. Also biased deployment, explanation, and system monitoring practices. What Patricia was talking about in terms of over-reliance or over-compliance or distrust that can come through in the actual implementation practices. There's also the bigger picture application injustices. To really move quickly now, the last issue that I'll just touch on is model interpretability. So in both of the studies I mentioned earlier, it was noted that the problem of model opacity and insufficient explainability is a big issue, and it signaled a kind of wider prioritization of predictive performance over interpretability in COVID-19 related machine learning applications. In their recommendations, Robert et al. Actually cautioned that researchers should aim to aid clinicians by providing interpretable predictions. They wrote that we stress the importance of not only reporting results, but also demonstrating model interpretability with methods such as saliency maps, which are necessary considerations for the adoption in clinical practice. And so this is a relevant opinion piece that stated the age of measuring performance based solely on traditional performance metrics is over. Model evaluation must take into consideration both performance and interpretability. And just to flag up as well, these issues really find their way, especially in digital pathology. And so here we can see some saliency maps, visualization of 4 whole slide images in a system that was trained to detect tumors. In the actual system, in the model development process, the deep neural net that was being trained was incorrectly predicting the absence of tumors, even though they are visually present at the bottom of the slide. And so what happens in the model, they basically used the saliency map, which is basically this heat map, to discern the areas of high prediction importance, which was in the red. And it helped the model developers discern that the neural net was incorrectly using the presence of fat tissue to indicate the absence of the tumor, an indication of bias in the trained model. Also, if we think about the importance of interpretability in the clinical decision support environment, we can see here, this is just a kind of visualization, again, of 2 study tumor entities. The red denotes the positive relevance, so in favor of the prediction of class cancer, while the blue denotes the negative relevance, contradicting the prediction of cancer. And what we can see is the heat map, when it's used as a support mechanism, helps enable pathologists to focus on problematic regions of the whole slide image, to examine the areas that the algorithmic model's flagging up as having higher positive relevance. So just to kind of now quickly jet ahead. So basically, what are some of the ways that we can actually confront these challenges in creating responsible data innovation ecosystems? Well, what did we do in the instance of Dekovid? First, we tackled the issue of all of these issues that were related to ethics and governance by kind of doing a rapid responsible research and innovation upskilling sprint, if you could call it that. We worked off of this paper I published in the Harvard Data Science Review in May of 2021. And we built out for Dekovid what we call the SAFE approach to responsible use of health data. So sustainable, safe, accountable, and transparent, fair and equitable, explainable, and interpretable. And we built a governance framework where we worked with a governance framework and suggested mechanisms of data stewardship and responsible health data use that built off of ONS's 5 safes or 6 safes as they've been interpreted, including safe projects, so the ethical use of data and patient public involvement and engagement, safe people, making sure users are accredited, have RRI training and are sufficiently prepared, safe settings, so thinking about secure access, trusted research environments, secure compute infrastructures, safe data, so thinking about fair data, responsible data linkage and data integrity, safe outputs, egress control, sustained privacy and traceability, and safe return, so responsibly connecting the research environment with the clinical and care environment when data has to move back and forth. We also built a responsible research practices tool, which basically supported those who are building predictive models, both in terms of a bias self-assessment, which you can see in the list on the left, and transparent reporting. Basically, the bias self-assessment took them through the design, development, deployment workflow, and then flagged up various biases that might arise. And same with the transparent reporting, took them through the process of constructing and writing the paper based on tripod, and brought them through that. Now, just one final bit of input about some objectives that we might prioritize in creating a responsible data innovation ecosystem for digital pathology. So first, securing an ethical, safe, equitable, and responsible ecosystem that is oriented to the public good and to the benefit of citizens and society. That, I think, is paramount when we think of building public trust. The public is really willing to share their data, as many studies have found. They just need to be confident that's going to be used for the public benefit and not used for necessarily just for private gain. And so the building on existing ethics standards and governance landscape will be important to this, and covering some of the areas I just talked about. Also, I'd say that just to also flag up, the existing ethics standards and governance landscape is exceptionally rich, especially when we think of all of the various standards and protocols that are associated with health informatics and the various dimensions of responsible data sharing that are associated with proper responsible data sharing in the health use case. Second objective would be to ensure ethics and governance principles and protocols are accessible, easily understandable, and inclusive. So this is really about clinicians and those who are working in digital pathology to carry out co-design of frameworks with a continuous commitments to accessible, easily understandable, and inclusive guidance. So starting from user needs, prioritizing the utilization of plain non-technical language and the presence of complex ideas in a jargon-free manner that is intelligible and accessible to non-specialists, and also really co-creating frameworks alongside impacted stakeholders and members of the wider community. Three, on the second to last slide now, to ensure social license, public consent, and patient trust, we need appropriate outreach, consultation, and engagement. So prioritizing PPIE, using patient and public participation as a building block of ensuring public trust, and safeguarding this as a dialogical process. And then finally, I think this is the trickiest one, but probably one of the more important ones, and that's really working towards organizational and participant readiness, so that the uptake and execution of any digital responsible digital ecosystem framework can be safeguarded and cultural transformation enabled. And so just think here that we think of readiness gaps arising where there's a disparity between the development and implementation of a new technology policy, so a technology policy, say, on AI ethics and governance, and the preparedness of social institutions, organizations, and actors to absorb, adapt to the changes brought about by that policy transformation. And so to meet the challenge, we would really need to identify and address potential readiness gaps in order to facilitate the cultural transformation needed and to safeguard the effective execution and uptake of the framework resources and processes. And so basically, I mean, I think this last objective is really interlocking. It involves having readiness for the uptake of the innovation, so having the proper kind of user training on the side of those who are going to be using the digital pathology technology, but also having a technology policy upskilling when it comes to implementing the proper ethics and governance frameworks in the actual data innovation ecosystem. So it's a really 360-degree need of readiness. It's not just located in the clinical or the design, development, and deployment context. So I think I'll stop there. I think I'm pretty close.